Good morning, everyone. I'm Helix, an AI health advisor. My purpose is to provide clear and reliable information, drawn from trusted medical sources like government health agencies, hospitals, and leading research centers in America and worldwide. It's a privilege to be with you today to discuss a topic that's crucial for your health, especially for anyone living with or at risk of diabetes. Let's talk about your skin. Now, you might be wondering, why is a doctor, particularly one focused on overall health, spending time on skin conditions? The answer is quite profound. Your skin, the largest organ of your body, is truly a window into your internal health. Think of it as a vital barometer, constantly providing clues about what's happening inside. In the context of diabetes and insulin resistance, these skin changes are often not just cosmetic concerns. They can be among the very first noticeable signs of underlying metabolic issues, sometimes even before you receive a formal diagnosis of diabetes. In fact, the prevalence of skin problems in people with diabetes is remarkably high. Studies estimate that anywhere from 30% to over 90% of individuals with diabetes will experience a dermatological issue at some point during their journey. This underscores why it's crucial for all of us, clinicians like myself, and importantly you, the patient, to recognize these signs promptly. The changes we see on the skin are not random. They are deeply rooted in the core metabolic imbalances of diabetes. We're talking about things like elevated insulin levels, persistently high blood sugar, and abnormal levels of fats in your blood. These imbalances can damage tiny blood vessels, affect your nerves, change the structure of your tissues, and even impact your immune system. Understanding these connections isn't just academic. It helps us diagnose earlier, assess your risk for other complications, and work together on a comprehensive management plan. Today, I want to take you through a detailed tour of these skin signs. We'll group them by what they tell us about the underlying problem, making it easier for you to understand and remember. Our goal is to empower you with knowledge so you can be an active participant in your own care. Let's begin. We'll start with the skin signs that are often the earliest visible clues of a disturbed metabolic state. These are frequently direct consequences of what we call hyperinsulinemia. That's when your body is producing high levels of insulin as it tries to keep your blood sugar normal, especially if you have insulin resistance. Because insulin is a powerful growth hormone, its excess can stimulate various skin cells to proliferate. This means these signs can appear years before your blood sugar levels are high enough for a formal diabetes diagnosis, offering a critical opportunity for early intervention. 1. Acanthosis, Nigricans, AN. This is perhaps the most recognized skin marker of insulin resistance. It appears as symmetrical, velvety, thickened, and hyperpigmented, meaning darker, patches of skin. The texture often feels finely bumpy or ridged. While you might see it on knuckles, elbows, or knees, it's most commonly found in body folds where skin rubs together, like the back and sides of your neck, your armpits, axillae, and your groin. Sometimes, people describe it as a dirty or soot-covered appearance that simply won't wash off, which can understandably be a cosmetic concern. Why does this happen? It's directly linked to high insulin levels. In insulin resistance, your pancreas works overtime, pumping out a lot of insulin. This excess insulin binds to special receptors on your skin cells, particularly on keratinocytes and fibroblasts. This binding acts like a signal, triggering these cells to grow and multiply, leading to the characteristic thickening and textural changes we see. It's more common in individuals with obesity and those with darker skin tones. What does it mean for you? AN is a powerful predictor for developing type 2 diabetes. Its presence, especially if you're overweight or obese, should be a red flag that warrants immediate screening for prediabetes or full-blown type 2 diabetes with tests like fasting glucose or A1C. What can you do? The best treatment is to address the root cause. Lifestyle changes, including weight loss, a healthier diet, and regular physical activity, are incredibly effective because they improve insulin sensitivity and lower insulin levels. While these measures can sometimes make the AN fade, topical creams like retinoids or those with lactic acid can help with the cosmetic appearance, but they don't treat the underlying metabolic issue. 2. Acrochordons, or skin tags. These are small, soft, benign skin growths that typically hang off the skin on a narrow stalk, which we call pedunculated. They are usually skin-colored or slightly darker. You'll often find them in areas of friction, much like AN, on your eyelids, neck, armpits, and groin. While 1 or 2 skin tags are common for many people, the presence of multiple skin tags is what catches our clinical attention. Why do they form? The mechanism is very similar to Acanthosis nigricans. High insulin and other growth factors promote the proliferation of skin cells, leading to these growths. Studies have shown a strong connection between multiple skin tags and high insulin levels, even in people who haven't yet shown high blood sugar. What does it mean for you? Numerous skin tags can be a visible marker for insulin resistance, metabolic syndrome, and an increased risk for type 2 diabetes. One study found that nearly 60% of people with skin tags had diabetes, compared to only 13% of those without. What can you do? Management is usually for cosmetic reasons, or if they get irritated. They are easily removed in a clinic setting by freezing, burning, or simply cutting them off. More importantly, addressing the underlying insulin resistance through lifestyle changes or medications like metformin may help prevent new ones from forming. 3. Hirsutism and persistent acne, vulgaris, in women. For women, the new onset of hirsutism, that's the growth of coarse, dark, male pattern hair on the face, chest, or back, or the development of acne that is persistent and resistant to typical treatments, can also be skin signs of an underlying endocrine imbalance driven by insulin resistance. Why does this happen? High insulin levels can directly stimulate your ovaries to produce more male hormones, known as androgens, like testosterone. At the same time, it can reduce the amount of a protein that binds to testosterone, leaving more free or active testosterone circulating in your body. These excess androgens then act on your skin, stimulating oil glands, leading to acne, and converting fine, nearly invisible hairs into coarse, visible ones, leading to hirsutism. This whole hormonal cascade is a central feature of polycystic ovary syndrome, or PCOS, which is very strongly linked to insulin resistance. What does it mean for you? If you're an adult woman experiencing new or severe hirsutism or acne, especially if it's alongside other signs like Acanthosis, Nigricans, or obesity, it should prompt a closer look for an underlying endocrine disorder like insulin resistance or PCOS. What can you do? Management needs a dual approach. Controlling the underlying insulin resistance through weight loss and sometimes medications like metformin is fundamental. This is often combined with specific skin treatments like oral contraceptives or anti-androgen medications for hirsutism and standard acne treatments. Now, let's move on to skin signs that typically indicate more long-standing or poorly controlled diabetes. These are often visible manifestations of damage that has already occurred to the body's small blood vessels, what we call microangiopathy, and to the peripheral nerves, known as neuropathy. High blood sugar is directly toxic to these structures over time, leading to a cascade of complications. Therefore, seeing any of these skin signs is a significant clinical finding, as it strongly suggests you might be at high risk for other, more severe systemic complications, such as damage to your eyes, retinopathy, kidneys, nephropathy, and heart. This usually calls for a more thorough and urgent systemic evaluation. 1. Diabetic dermopathy, Shin spots. This is one of the most common skin issues in diabetes. It appears as asymptomatic, meaning it causes no symptoms. Light brown or reddish, well-defined round or oval patches, mostly on your shins. They might start scaly and then become slightly indented. Because they don't cause any discomfort and can look like simple age spots, they are often overlooked. However, having 4 or more of these lesions is considered highly specific for diabetes. Why do they appear? This is a direct result of diabetic microangiopathy. Chronic high blood sugar damages the small blood vessels supplying your skin, leading to reduced blood flow and increased fragility. Minor, often unnoticed, bumps or scrapes to your shins can cause tiny bleeds, and the iron from those blood cells gets deposited in the skin, creating the characteristic brown color. It's essentially your body's altered response to minor injury due to compromised circulation. What does it mean for you? While the spots themselves are harmless and don't turn into ulcers, their clinical significance is profound. They are a strong and easily visible marker for other, more severe microvascular complications. If you have shin spots, it suggests a higher likelihood of also having diabetic retinopathy, eye damage, nephropathy, kidney damage, and neuropathy, nerve damage. What can you do? No specific treatment is needed for the spots themselves, but their presence should prompt your doctor to evaluate you thoroughly for these other complications. The focus of management is on achieving and maintaining strict blood sugar control to slow the progression of the underlying systemic vascular disease. Makeup can be used if they bother you cosmetically. 2. Necrobiosis lipoidica, NL. This is a rare but very distinctive and sometimes disfiguring chronic skin condition. It often begins as small, firm, reddish-purple bumps that slowly grow over months or years, joining together to form larger, well-defined plaques. A mature plaque has a unique look, a raised reddish or purplish border surrounding a waxy, thinned, yellowish-brown center, often with tiny, visible dilated blood vessels, called telangiectasias. NL predominantly occurs on the shins and is significantly more common in women and in patients with type 1 diabetes. These lesions can be itchy and painful, and the thin, fragile skin in the center is highly susceptible to breaking open and forming ulcers, even from minor trauma. Why does it happen? The exact cause isn't fully understood, but it's fundamentally an inflammatory disorder linked to diabetic microangiopathy. It involves inflammation of blood vessels, damage to collagen in the skin, and abnormal fat deposition, which gives it that yellowish appearance. What does it mean for you? NL is strongly associated with diabetes, so its presence should always prompt testing for diabetes. The most significant complication is ulceration, which happens in about 1/3 of cases. These ulcers are notoriously difficult to heal due to poor circulation and fragile skin, and they carry a high risk of secondary infection. What can you do? Management is very challenging. While strict blood sugar control is essential, it often doesn't reverse existing lesions. Treatment focuses on controlling inflammation, often with strong topical or injectable corticosteroids. Other treatments like light therapy or immune-suppressing medications may also be tried. Any ulcers require aggressive and specialized wound care. 3. Bullosis diabeticorum, diabetic blisters. This is a striking but rare skin manifestation, characterized by the spontaneous appearance of non-inflammatory, tense blisters. These blisters arise on skin that isn't red or inflamed underneath, and they are filled with clear, sterile fluid. They can look similar to burn blisters, but are typically painless. You'll usually find them on your feet, toes, hands, and fingers, but they can also appear on legs and forearms. Why do they form? The exact cause is still unclear, but it's strongly associated with long-standing diabetes and the presence of diabetic neuropathy, or nerve damage. Theories suggest that tiny blood vessel changes, microangiopathy, might lead to skin layers separating, or that trauma to skin that you can't feel due to neuropathy might be a trigger. Excessive sun exposure has also been implicated. What does it mean for you? Diabetic blisters are a distinct marker for diabetes. While the blisters themselves are benign, the main concern is preventing them from rupturing, which could lead to a secondary bacterial infection, a significant risk, especially on the feet of someone with diabetes. What can you do? Management is primarily conservative. It's important not to intentionally pop or drain the blisters. Keep the area clean and apply a topical antibiotic ointment and a sterile, non-adherent dressing to protect the blister roof. They usually heal spontaneously without scarring within 2 to 6 weeks. Improving your blood sugar control is the only systemic treatment known to be helpful. 4. Impaired wound, healing, and diabetic foot ulcers. This is a severe and limb-threatening complication of diabetes. It often starts with subtle signs on the feet: localized redness, warmth, swelling, or the formation of calluses, corns, and blisters. What makes this dangerous is that minor injuries, like a small cut, scrape, or blister, which would be trivial for someone without diabetes, fail to heal properly and can quickly turn into open sores, or ulcers. These ulcers often look like a punched-out hole and can be shallow or very deep, sometimes exposing underlying tendons or bone. If infected, they may produce pus or a foul odor. Why is healing impaired? This is a devastating synergy of 3 core diabetic complications. Neuropathy, nerve damage. Sensory neuropathy means you lose the protective sensation in your feet, so you might not feel minor trauma, pressure from ill-fitting shoes, or even a blister. Autonomic neuropathy disrupts sweat and oil production, leading to very dry, cracked skin, which provides an easy entry point for bacteria. Motor neuropathy can cause foot deformities like hammer toes, creating abnormal pressure points prone to breaking down. Vascular disease, poor circulation. Both small and large blood vessel damage are common in diabetes, leading to peripheral artery disease, PAD. This severely reduces blood flow to your feet, impairing the delivery of oxygen, nutrients, and immune cells essential for tissue repair and fighting infection. Immune dysfunction. Chronic high blood sugar directly impairs the function of your white blood cells, especially neutrophils, which are crucial for fighting off pathogens. What does it mean for you? Diabetic foot ulcers are a major cause of hospitalization and are the leading cause of non-traumatic lower limb amputations in the diabetic population. What can you do? Prevention is the absolute cornerstone of management. This relies heavily on patient education and proactive care. Daily self-inspection of your feet is non-negotiable. Wear properly fitting therapeutic footwear and attend regular podiatric appointments for professional foot care. Once an ulcer forms, it requires an aggressive, multidisciplinary approach involving specialized boots or casts to take pressure off the area. Meticulous cleaning of the wound, diligent infection control with antibiotics, and often advanced wound care techniques. Throughout this, achieving optimal blood sugar control is fundamental to support healing. 5. Rubiosis Waxy, diabetic flush. This skin sign is characterized by a persistent, diffuse redness of the face. It can be subtle and is often overlooked, but some reports suggest it's quite common, affecting up to 59% of hospitalized diabetic patients. Why does it happen? Traditionally, it was thought to be due to microangiopathy, sluggish blood flow and dilated superficial blood vessels in the facial skin. However, recent research has challenged this, and the precise mechanism is still being investigated. What does it mean for you? Regardless of the exact cause, Rubiosis Waxy is associated with poor blood sugar control. While the condition itself is harmless, its presence should alert your doctor to the possibility of suboptimal diabetes management and prompt a search for other more serious microangiopathic complications, particularly diabetic retinopathy, eye damage. What can you do? There's no specific treatment for the facial flushing itself. The main goal is to achieve and maintain strict blood sugar control, which may improve its appearance. 6. Generalized pruritus and xerosis, itchy and dry skin. Itching, or pruritus, is an extremely common and often distressing symptom for people with diabetes, significantly impacting quality of life. The itching can be localized to specific areas, like your lower legs, often a sign of poor circulation there, or it can be generalized. The skin is frequently visibly dry, scaly, and may show signs of chronic scratching like excoriations, scratch marks, or lichenification, a leathery thickening of the skin. Why does this happen? Diabetic itching is multifactorial and complex, arising from several mechanisms working together. Autonomic neuropathy, damage to nerves. Controlling sweat and oil glands impairs their function, leading to decreased natural moisturization and severe dryness, making your skin barrier vulnerable to irritants. Hyperglycemia. Persistently high blood sugar can cause systemic dehydration, pulling fluid from skin cells and contributing to dryness. Sensory neuropathy. Damage to the small nerve fibers that transmit itch sensations can cause them to fire abnormally, creating a sensation of itching even without a primary skin irritant. We call this neuropathic itch. Advanced glycation end products, AGEs. The accumulation of AGEs can further disrupt the skin barrier. Associated conditions. Sometimes itching isn't directly from diabetes, but from a secondary fungal infection, or it can be a sign of a more severe complication, such as chronic kidney disease-associated pruritus in patients who have developed diabetic nephropathy. What can you do? Management aims to break the itch-scratch cycle, restore your skin's barrier function, and address the underlying causes. Achieving excellent blood sugar control is fundamental. Dermatological care includes aggressive and consistent moisturization with high-quality creams, especially those containing ceramides or urea. Avoid long, hot showers and harsh, fragrant soaps, which strip your skin of its natural oils. For symptomatic relief, topical anti-itch agents can be helpful. For suspected neuropathic itch, your doctor might prescribe systemic medications like gabapentin or pregabalin. And remember to screen for kidney disease or fungal infections if itching is severe or persistent. Next, we'll discuss a group of skin conditions characterized by the hardening, thickening, and loss of elasticity of your skin and underlying connective tissues. The central theme here is the accumulation of what we call advanced glycation end products, or AGEs. When you have chronic high blood sugar, excess glucose molecules irreversibly bind to long-lived proteins, most notably collagen, which is a major component of your skin. This process creates abnormal connections, making your collagen stiff, thickened, and resistant to normal breakdown. This is a slow, cumulative process, which is why these conditions typically appear in individuals with long-standing, often poorly controlled diabetes. The appearance of these sclerotic changes is significant because it reflects systemic tissue damage that is also occurring in other organs. So, these skin signs are strong predictors of other microvascular complications. 1. Digital sclerosis. This presents as tight, thick, waxy textured skin, most commonly on the back surfaces of your fingers and toes. The affected skin becomes hardened and difficult to pinch. This skin change often leads to stiffness and reduced movement in the small joints of your fingers and toes. In severe, long-standing cases, the thickening can be so pronounced that patients describe a sensation of having pebbles in their fingertips. Why does it happen? It's a direct consequence of chronic high blood sugar, leading to the formation and accumulation of AGEs in the skin's collagen. These AGEs create abnormal crosslinks between collagen fibers, resulting in thick, disorganized collagen bundles that replace normal, flexible connective tissue. It's particularly common in patients with type 1 diabetes. What does it mean for you? Digital sclerosis is a clear marker of long-standing and often inadequately controlled diabetes. It's a key component of a broader condition known as diabetic chiroarthropathy, or stiff hand syndrome. What can you do? The cornerstone of management is achieving and maintaining tight blood sugar control to prevent further progression. To address existing stiffness and preserve function, Physical and occupational therapy are crucial to maintain joint range of motion and prevent fixed contractions. Regular use of moisturizers and emollients can also help soften the skin surface. 2. Diabetic arthropathy, limited joint mobility syndrome. This is a more advanced condition that encompasses digital sclerosis, but involves the joints more significantly. It's defined by painless, limited extension of the main finger joints, MCPs and PIPs, along with the characteristic thick, waxy skin of the hands. Patients find they can't fully straighten their fingers or press their hands flat together. This limitation leads to two classic diagnostic signs. The prayer sign. You can't fully bring the palms and fingers of your hands together when trying to press them in a prayer-like position. The tabletop sign. You're unable to lay the entire palm and fingers of your hand flat on a horizontal surface. Why does it happen? The underlying mechanism is the same as digital sclerosis: extensive accumulation of AGs within the tissues around the joints, including collagen, tendons, and ligaments. This makes these connective tissues stiff, thickened, and resistant to normal turnover. Poor circulation due to microangiopathy also contributes. What does it mean for you? Diabetic arthropathy is strongly associated with the duration of your diabetes and serves as an easily observable marker for patients who are at high risk for other, more severe microvascular complications, especially diabetic retinopathy, eye damage, and nephropathy, kidney damage. The condition itself is generally considered irreversible. What can you do? Management focuses on preventing further progression through strict blood sugar control. Physical and occupational therapy are essential to preserve hand function, improve grip strength, and prevent further contractions. 3. Scleredema diabeticorum. This is a rare but serious connective tissue disorder characterized by diffuse, symmetrical, non-pitting, woody hardening and thickening of the skin. It classically affects the upper back, the back of the neck, and the shoulders, often in a cape-like or shawl-like distribution. A key feature is that the hands and feet are typically spared, which helps distinguish it from other conditions like scleroderma. The affected skin can sometimes take on an orange peel texture. In severe cases, this profound thickening and hardening can severely restrict movement of your upper body, shoulders, and neck, and can even impair breathing by limiting chest wall expansion. Why does it happen? The exact cause isn't fully understood, but like other sclerotic conditions, it's linked to the abnormal deposition of glycosylated collagen and a substance called mucin in the deeper layers of the skin. This process is thought to be stimulated by the metabolic environment of chronic high blood sugar and high insulin levels. It's most frequently seen in obese men with long-standing, poorly controlled type 2 diabetes. What does it mean for you? Scleredema diabeticorum is a marker of severe, long-duration, and poorly controlled diabetes. It can significantly impact your quality of life due to pain and severely restricted mobility. What can you do? Treatment is exceptionally difficult, and the condition often persists and progresses even with good blood sugar control. No single therapy has consistently proven effective. Various treatments have been tried with limited success, including light therapy, electron beam radiation, and systemic immune-suppressing medications. Physical therapy is a critical component to help maintain range of motion and prevent functional decline. Now, let's discuss conditions that are direct manifestations of severe imbalances in your blood fats, or dyslipidemia. These skin signs are not just on the surface, they represent visible deposits of systemic metabolic excess. Their appearance serves as an urgent clinical warning of severe high triglycerides or high cholesterol. The link to diabetes lies in insulin's crucial role in regulating fat metabolism. When insulin is deficient or there's profound insulin resistance, an enzyme called lipoprotein lipase, which breaks down triglycerides in your bloodstream, doesn't work properly. This leads to a massive buildup of triglycerides and cholesterol-rich particles in your blood. These excess fats then leak out of your tiny blood vessels in the skin and are engulfed by immune cells, forming visible lesions. So, seeing these signs is like seeing a lipemic, or fatty blood sample, right on your skin, signaling a high acute risk for pancreatitis from very high triglycerides and accelerated heart disease from high cholesterol. 1. Eruptive xanthomatosis. This is a dramatic skin condition characterized by the sudden eruption of clusters of small, firm, yellow or reddish-yellow bumps, typically about the size of a pea. A key diagnostic feature is the presence of a reddish halo surrounding each bump. The lesions are frequently itchy and can be tender to the touch. They tend to appear on the extensor surfaces of your body, meaning areas that straighten, and areas of pressure, most commonly on your buttocks, thighs, elbows, and knees. Why does it happen? This is a direct consequence of severely high triglycerides in your blood, often soaring above 2,000 dl, whereas normal is below 150 dl. In uncontrolled diabetes, insulin deficiency or resistance severely impairs the enzyme that clears these fats from your circulation. The excess fats leak out of skin capillaries and are engulfed by immune cells, which become engorged with fat and form these characteristic lesions. What does it mean for you? Eruptive xanthomatosis is an urgent and unmistakable sign of uncontrolled diabetes or another cause of severe high triglycerides. In some cases, it can be the very first sign that leads to a diabetes diagnosis. The extremely high triglycerides place you at a very high and immediate risk for developing acute, potentially life-threatening pancreatitis. What can you do? Management is urgent and focuses on aggressively lowering both your blood triglyceride and glucose levels. The skin lesions themselves will resolve spontaneously over several weeks to months once the underlying metabolic issue is corrected. The therapeutic strategy includes strict blood sugar control, often needing insulin therapy, lipid-lowering medications like fibrates, and a very low-fat diet with complete avoidance of alcohol. 2. Xantholasma. Xantholasma. Palpebrarum appears as soft, yellowish, flat-topped bumps or plaques that show up symmetrically on or around your eyelids. They have a strong preference for the inner corner of your eye and are typically painless. Why does it happen? These are a specific type of xanthoma caused by the deposition of cholesterol-rich fats within immune cells in the skin. While about half of patients with xantholasma have underlying high cholesterol, most commonly high LDL cholesterol, it can also occur in people with normal blood fat levels. In the context of diabetes, xantholasma is often a sign of diabetic dyslipidemia, which is characterized by high triglycerides, low good HDL cholesterol, and often small, dense, bad LDL particles. What does it mean for you? The primary clinical significance of xantholasma is its role as a skin marker for high cholesterol, and, importantly, as an independent risk factor for atherosclerosis, heart disease, and heart attacks. Its presence should prompt a comprehensive cardiovascular risk assessment, including a full fasting lipid profile. What can you do? Management involves a two-pronged approach. First, and most importantly, the underlying dyslipidemia must be addressed through lifestyle modifications like diet and exercise, and lipid-lowering medications, most commonly statins, to reduce your cardiovascular risk. It's important to understand that these systemic treatments, while crucial for your overall health, may not make the existing skin lesions disappear. Second, if the xantholasmas are a cosmetic concern, they can be removed using surgical excision, laser, freezing, or chemical peels. However, recurrence after removal is common, especially if the underlying lipid abnormalities are not adequately controlled. Now, we'll delve into skin diseases that, while not directly caused by the metabolic shifts of diabetes, share a common ground of immune dysregulation and inflammation. The relationship can be complex. For type 1 diabetes, which is an autoimmune disease itself, its association with other autoimmune conditions like vitiligo is a classic example of polyautoimmunity, driven by shared genetic predispositions that lead the immune system to attack multiple different tissues. For type 2 diabetes, the link with chronic inflammatory diseases like psoriasis highlights a cycle where the low-grade systemic inflammation of metabolic syndrome can both trigger and worsen the skin disease. Recognizing these associations is crucial for comprehensive patient care. 1. Granuloma annulare, GA. This condition is characterized by asymptomatic, skin-colored red, pink, or bluish bumps that gradually join together to form annular or ring-shaped or arc-shaped plaques. The center of the ring is often clear or slightly depressed. You'll typically find these lesions on the back surfaces of your hands and feet, as well as on your fingers and ears. Why does it happen? The exact cause of GA is unknown, but it involves a type of inflammation in the skin. While many people with localized GA do not have diabetes, multiple studies have shown an association between diabetes and the widespread or disseminated form of GA, where lesions are over large areas of the body. The connection may stem from a diabetes-related alteration in immune cell function or connective tissue. What does it mean for you? The clinical significance lies in the potential association with underlying diabetes. The presence of widespread or recurrent GA should prompt your doctor to consider screening you for diabetes. What can you do? In most cases, GA is self-limiting and doesn't require treatment, as the lesions often resolve spontaneously within a few months to 2 years. For persistent, itchy, or cosmetically bothersome cases, treatment options include strong topical or injectable corticosteroids, cryotherapy, freezing, or phototherapy, light therapy. 2. Psoriasis, the immunometabolic link. Psoriasis is a chronic, immune-mediated inflammatory disease that presents as well-defined red plaques covered with silvery white scales. It most commonly affects your elbows, knees, scalp, and lower back. It is now well established that psoriasis is not just a skin disease, but a systemic inflammatory condition with a strong bidirectional link to type 2 diabetes and metabolic syndrome. Why the connection? This immunometabolic link is driven by shared inflammatory pathways. Psoriasis, worsening insulin resistance. The chronic inflammation inherent to psoriasis, driven by inflammatory proteins, isn't confined to the skin. These proteins circulate throughout your body and can interfere with insulin signaling, promoting or worsening insulin resistance. Obesity causes diabetes, worsening psoriasis. Conversely, the low-grade chronic inflammation associated with obesity and insulin resistance can worsen psoriasis. Fat tissue, particularly, acts like an active endocrine organ, secreting inflammatory substances that can trigger or aggravate psoriatic skin lesions. This creates a vicious cycle where each condition can perpetuate the other. They also share common genetic pathways and lifestyle risk factors like obesity and smoking. What does it mean for you? This link has profound clinical implications. Patients with psoriasis, particularly moderate to severe cases, have a significantly increased risk of developing type 2 diabetes and should be screened regularly. The presence of both conditions also complicates treatment decisions. What can you do? Management must be integrated, with lifestyle modifications, weight loss, a healthy diet, and exercise being crucial for improving both conditions. From a medication standpoint, some diabetes medications have been observed to improve psoriasis symptoms. Conversely, certain traditional psoriasis treatments, like systemic corticosteroids, can elevate blood sugar and worsen diabetes control, requiring careful use. Newer biologic therapies that target specific inflammatory proteins are often safer and can be effective for both the skin and associated metabolic inflammation. 3. Lichen planus. Lichen planus is an inflammatory condition classically described by the 4 Ps. It's pruritic, itchy, polygonal, many-sided, purple, papules, and plaques. A fine, white, lace-like network called Wickham's striae may be visible on the surface of the lesions. It most commonly affects the flexor surfaces of your wrists and ankles, but it can also involve your mouth, oral lichen planus, nails, and scalp, where it can cause scarring hair loss. Why does it happen? The exact cause is unknown, but it's considered an immune-mediated process. Studies have noted that it's particularly common among people with diabetes, though the association is not as strong as with some other conditions. The link may be related to a generalized state of immune dysregulation or chronic inflammation present in diabetes. What does it mean for you? Its presence can be a clue to investigate for an underlying systemic condition. Oral lichen planus is particularly noteworthy because it carries a small but recognized risk of malignant transformation to a type of skin cancer, necessitating regular, long-term monitoring by a dentist or oral medicine specialist. What can you do? There's no cure for lichen planus, so treatment aims to control symptoms. Self-care is important and includes avoiding skin injury, using cool compresses to relieve itching, and practicing gentle skin and oral hygiene. For oral lesions, avoiding trigger foods like spicy, salty, or acidic items can reduce irritation. Medical treatment is centered on corticosteroids, either topical or, in severe cases, oral. Other options for symptom control include systemic antihistamines for itching, oral retinoids, and light therapy. 4. Vitiligo, a shared autoimmune pathway with type 1. Diabetes. Vitiligo is an acquired autoimmune disorder characterized by the progressive destruction of melanocytes, which are the pigment-producing cells in your skin. This results in the appearance of well-defined, milky white, non-scaly patches on the skin. Why the link? The link between vitiligo and diabetes is almost exclusively with type 1 diabetes, and this association is a classic example of polyautoimmunity. Both are autoimmune diseases, where your body's immune system mistakenly targets and destroys its own cells, melanocytes in the skin for vitiligo, and insulin-producing cells in the pancreas for type 1 diabetes. The connection is rooted in a shared genetic susceptibility. Several genetic factors that increase the risk for type 1 diabetes also increase the risk for vitiligo and other autoimmune diseases. Research has identified common inflammatory pathways implicated in both conditions. What does it mean for you? The clinical significance of this shared origin is that if you have type 1 diabetes, you are at a higher risk of developing vitiligo. Conversely, if you have vitiligo, you are at a higher risk for type 1 diabetes and other autoimmune disorders, most notably autoimmune thyroid disease. The presence of one of these conditions should increase clinical vigilance and prompt consideration for screening for associated autoimmune diseases. What can you do? Management of vitiligo focuses on halting the autoimmune process and stimulating repigmentation. Treatment options include topical corticosteroids, other topical medications like calcineurin inhibitors, and various forms of phototherapy, particularly narrowband UVB light therapy. Sun protection is a critical component of care, as the depigmented skin has lost its natural defense against UV radiation and is highly susceptible to sunburn. Next, let's talk about the increased susceptibility to cutaneous infections in individuals with diabetes. People with diabetes, especially when their blood sugar control is poor, are more prone to skin infections. While these infections are common in the general population, in a diabetic person, they tend to occur more frequently, with increased severity and a higher rate of recurrence. This vulnerability stems from a permissive environment created by chronic high blood sugar. High glucose levels provide a rich nutrient source for pathogens, especially fungi, while simultaneously weakening your body's immune defenses. High blood sugar directly impairs the function of key immune cells, like neutrophils, hindering their ability to migrate to infection sites and effectively destroy invading microbes. Additionally, diabetic complications like neuropathy and poor circulation lead to a compromised skin barrier. Dry, cracked skin creates easy entry points for bacteria, and reduced blood flow impedes the delivery of immune cells to the site. This combination explains why infections are not only more common but also more difficult to eradicate in this patient population. 1. Bacterial infections. Bacterial skin infections in diabetic patients can show up in various forms. Common ones include styes, acute infections of eyelid glands, boils or furuncles, deep infections of a hair follicle, folliculitis, superficial infections of multiple hair follicles, carbuncles, larger, deeper abscesses formed by multiple boils, and paronychia, infections around fingernails or toenails. The affected areas are typically hot, swollen, red, and painful. The most common culprit is Staphylococcus aureus, including antibiotic-resistant strains like MRSA. Why are you more susceptible? The underlying reason is the impairment of your immune response by poorly controlled diabetes. High blood glucose levels directly inhibit crucial functions of your neutrophils, which are your body's primary defenders against bacteria. This includes their ability to move towards an infection and their ability to engulf and destroy bacteria. What does it mean for you? Frequent or severe bacterial infections often indicate poor blood sugar control and a compromised immune system. What can you do? Management requires prompt diagnosis and treatment with appropriate antibiotics to prevent the infection from spreading deeper or becoming systemic. Incision and drainage may be necessary for abscesses like carbuncles. Fundamentally, achieving good blood sugar control is essential to restore immune function and help your body clear the infection and prevent recurrence. 2. Fungal infections, mycoses. Fungal infections are also exceedingly common in individuals with diabetes. The yeast Candida albicans is a frequent cause. Candidal intertrigo appears as an itchy, moist, bright red rash, often surrounded by characteristic satellite pustules or tiny blisters. It thrives in warm, moist skin folds, making areas under the breasts, in the armpits, in the groin, and between the toes common sites of infection. Other common fungal infections include dermatophyte infections. These are caused by mold-like fungi and include Tinea pedis, athlete's foot, which causes scaling, maceration, softening due to moisture, and itching between the toes, Tinea cruris, jock itch, and Tinea corporis, ringworm, which presents as ring-shaped, scaly patches. Onychomycosis. This is a fungal infection of the nail, causing your nails to become thickened, discolored, yellow or brown, brittle, and separated from the nail bed. Why are you more susceptible? The increased susceptibility is twofold. First, fungi, especially yeasts like Candida, flourish in high glucose environments, making the skin and mucous membranes of a hyperglycemic individual an ideal breeding ground. Second, the compromised immune status associated with diabetes reduces your body's ability to keep fungal populations in check. What can you do? Management involves treatment with appropriate antifungal medications, which may be topical creams, powders, or solutions, or for more extensive or stubborn infections like onychomycosis, oral medications. A critical preventative measure is patient education on keeping skin, especially in skin folds, clean and thoroughly dry. As with bacterial infections, long-term prevention of recurrence is heavily dependent on maintaining good blood sugar control. Finally, we'll cover a group of less common but clinically important skin conditions associated with diabetes, the rare perforating and allergic dermatoses. The perforating dermatoses are particularly significant because their presence often signals a more advanced stage of disease, specifically linking diabetes with chronic kidney failure. They are, in essence, skin markers of severe, multi-organ systemic disease, particularly diabetic nephropathy. Their pathophysiology is thought to involve metabolic derangements from kidney failure, which alter skin structure combined with the microtrauma of intense scratching, leading to the characteristic extrusion of dermal components through the skin. 1. Acquired reactive perforating, collagenosis, ARPC. ARPC is a disorder where altered collagen fibers are pathologically extruded through the outer layer of the skin. Clinically, it appears as intensely itchy red, umbilicated papules, meaning they have a central depression, each with a distinctive central plug of hardened skin. The lesions are often found on the extensor surfaces of your limbs and trunk. A key feature is the Kubner phenomenon, where new lesions develop at sites of skin trauma, such as from scratching. Why does it happen? The acquired form of this disease is strongly associated with underlying systemic conditions, most notably diabetes mellitus and chronic kidney disease, especially in patients undergoing dialysis. The intense itching that often accompanies kidney failure is thought to be a key trigger, with the resulting microtrauma from scratching initiating the process of abnormal collagen elimination. What does it mean for you? Its presence is a marker of severe multi-organ systemic disease, particularly diabetic nephropathy. What can you do? Management of ARPC is challenging. The primary goals are to manage the underlying systemic diseases, diabetes and kidney failure, and to control the severe and often debilitating itching. Treatment options are varied and often used in combination, including strong topical corticosteroids, topical retinoids, moisturizers, systemic antihistamines for itching, phototherapy, light therapy, and a medication called allopurinol. 2. Chiral disease. Chiral disease presents with clinical features similar to ARPC, including multiple distinct hyperkeratotic papules and nodules, meaning they are thickened and contain a large central keratin plug. The lesions are most common on the lower extremities and may show a linear pattern due to new lesions appearing from scratching. Why does it happen? First described in a diabetic woman in 1916. Chiral disease is another acquired perforating dermatosis, characterized by the extrusion of abnormal, rapidly produced keratin through the skin. Like ARPC, it has a very strong association with the dual diagnosis of diabetes and chronic kidney failure. The pathophysiology is thought to be driven by metabolic factors related to kidney failure, such as uremia, high waste products in blood, and hyperphosphatemia, high phosphate levels, which are hypothesized to deposit in the skin and trigger this abnormal keratinization and extrusion. What does it mean for you? Similar to ARPC, it's a marker of severe systemic disease, often involving diabetic nephropathy. What can you do? Treatment is difficult and mirrors the approach for ARPC. It's centered on managing the underlying systemic diseases and providing symptomatic relief for the skin lesions and itching. Therapeutic options include agents that help reduce the thickened plugs, such as salicylic acid or urea, topical retinoids, and phototherapy. 3. Allergic reactions to anti-diabetic medications. Allergic reactions to the medications used to treat diabetes can also show up on your skin. These reactions can be localized, such as red rashes, hardened bumps, or even depressions, called lipoatrophy, at the sites where insulin is injected. Alternatively, they can be generalized, presenting as a widespread measles-like rash or urticaria, hives, in response to an oral anti-diabetic agent. Why do they happen? This is a standard immunological hypersensitivity reaction, which can be an immediate allergic response or a delayed one to the active drug molecule or one of the inactive ingredients in the medication. What does it mean for you? It means you're having an allergic reaction to a component of your diabetes medication. What can you do? Management requires correctly identifying the offending drug and stopping it. Your physician must then select an alternative medication from a different class to manage your diabetes. The skin symptoms of the allergic reaction can be treated with oral antihistamines for itching and hives, and topical or systemic corticosteroids to reduce inflammation. Concluding. So, as you can see, the cutaneous manifestations of diabetes and insulin resistance are incredibly diverse and numerous, ranging from common infections to very rare disorders. This comprehensive review today underscores a critical clinical principle. Your skin is an invaluable and readily accessible window into your underlying metabolic status. Recognizing these dermatological signs isn't just about managing a skin condition, it's an essential component of holistic diabetes care. Signs like Acanthosis nigricans and multiple skin tags can serve as the first alert to underlying insulin resistance, allowing for early diagnosis and preventative intervention. The appearance of conditions like diabetic dermopathy or chiroarthropathy can act as a barometer for long-standing blood sugar control and a powerful predictor for concurrent systemic microvascular disease, prompting necessary risk stratification and screening. And the sudden eruption of xanthomas signals a metabolic emergency requiring urgent intervention. The management of these conditions is always twofold, requiring both systemic and local approaches. The cornerstone of therapy is achieving and maintaining optimal blood sugar and lipid control, which addresses the root cause of these manifestations. This must be paired with diligent, targeted skin care and robust patient education focused on preventative self-care, particularly for your feet. An integrated interprofessional team approach involving your dermatologist, endocrinologist, podiatrist, and diabetes educator is paramount to your success. To help you proactively care for your skin and prevent serious complications, I want to leave you with a few key self-care strategies that should become part of your daily routine. General skin health. Always keep your skin clean and dry, paying special attention to skin folds like your armpits, groin, and underbreasts to reduce moisture that encourages fungal and bacterial growth. Use mild, fragrance-free hypoallergenic cleansers and soaps to avoid irritating sensitive skin. Bathe or shower in lukewarm, not hot, water, and limit your bathing time, as hot water strips your skin of its natural protective oils. Most importantly, moisturize your skin daily with a quality emollient, ideally one containing ceramides or urea. Apply it after bathing to lock in moisture, which restores your skin's barrier, prevents cracking, and reduces itching. Daily foot inspection. This is crucial. Visually inspect the entire surface of both feet every single day, including the soles, heels, and especially between the toes. Early detection of cuts, sores, blisters, redness, or swelling is critical to preventing ulcers. Use a mirror or ask a family member for help if needed. Also, check for changes in skin color or temperature, and for any signs of drainage or a foul odor. These can be early signs of infection or severe circulatory compromise requiring immediate medical attention. Footwear and nail care. Wear properly fitting, supportive shoes, and clean, dry socks. Never walk barefoot even indoors to prevent injuries. Trim your toenails straight across and gently file any sharp edges. Do not cut your cuticles, as this can lead to ingrown nails and infections. If you're unable to do this safely, please seek professional podiatric care. Callus care. You can gently use a pumice stone on wet skin after bathing to keep calluses from building up, which prevents them from cracking or developing into ulcers. However, never attempt to cut calluses yourself or use chemical corn callus removers. These carry a very high risk of causing a deep wound and infection and must be done by a podiatrist. Minor wound care. Wash any minor cut, scrape, or blister immediately with mild soap and water to cleanse the wound and reduce infection risk. Avoid harsh antiseptics like alcohol or hydrogen peroxide unless specifically directed by your doctor. Apply an antibiotic ointment only if recommended by a physician, and always cover the wound with a sterile bandage or gauze. Change the bandage daily and monitor the wound closely for any signs of infection, such as increasing redness, swelling, pain, warmth, or pus. If the wound is not healing or shows signs of infection, seek medical attention immediately. Blister care. For any blisters, do not intentionally pop or drain them. The intact blister roof provides a natural sterile barrier against infection. Gently wash the area, apply antibiotic ointment, and cover with a sterile, non-adherent dressing, changing it daily. If it ruptures on its own, then follow the minor wound care guidelines. Ultimately, your ability as a patient to recognize, understand, and act upon these skin signs of diabetes is a powerful tool to reduce your risk of serious complications, improve your overall quality of life, and ensure you remain at the center of your healthcare team. Next week, we're dropping a powerful video, The Hidden Secrets of Diabetic Diets. If that sounds interesting, give this video a thumbs up and hit subscribe. Tap the notification bell so YouTube knows to recommend it to you. Trust me, you don't want to miss it, because it's not the medications, it's the diet that holds the key to your health. See you next week. Bye-bye. And may your health keep getting better.